Well, gents, thanks for taking the time out, joining me here on the floor at TCT 2025. Appreciate it.
Happy to be here.
Thanks for having us.
So we were chatting early before we start rolling. What's been the take on TCT? It feels like it's back.
Yeah, I mean, it's definitely back. It's packed. All the sessions are filled with people, even at 7:30 in the morning. So it's been phenomenal to see it.
Yeah. Greg, your view?
Well, I ran this meeting for 25 years, and it's great to see that it's continuing as strong as it is. I think the attendance up here seems as high as we ever had it.
Yeah, everybody has shown. Your views on it from the heart failure perspective?
Absolutely. I mean, I think what we talked about earlier, we see more and more heart failure penetrating in the interventional world, and I think it's just about right because we have a lot of technologies that we rely on our interventional colleagues to help us with.
Why do we see heart failure starting to come into the TCT aperture where we haven't seen it as much over the years? Have we gotten really good at treating certain procedures and move them down line?
Well, I mean, heart failure has always been around, and I mean, it's always been really the number one, cause of both rehospitalizations in the country as well as economic resource, consumption, utilization. But until probably the last 5 to 8 years, we haven't had many devices to treat it. It was mainly a pharmacology approach, and drug therapies continue to get better and better. Then cardiac resynchronization therapy came out and shown to clearly improve outcomes. And now we've got a whole lot of new device-based approaches that is making, I think, this community very interested in our ability to potentially change the prognosis for very sick patients.
I mean, they talk about the pillars of pharmacologic therapy for heart failure, and it's to the point where, certainly Dr. Stone has had a large part to do with this. There are certain therapies, interventional therapies, that are considered right in line that are just as important as the pillars, the classic pharmacologic pillars. I mean, so these device-based therapies are reaching that stage now where it's not just, you might want to do this. No, you should do this. And this definitely helps improve outcomes.
And when we think about the pharmacological solutions, but also the device solutions, how do you view it as a heart failure specialist now having alternatives?
I think it's, it's really, we have to think of devices being complementary to pharmacological therapies. Unfortunately, for many years, we're biased to say, try drug A, B, C, and D, and then if you fail them, we'll give you a device, which is the wrong thing to do. We have devices that are complementary to drugs, right? Mitral tears, for instance, or CRTs, or other devices. So we have a plethora of devices that can help pharmacological therapy and work, in synchrony.
Yeah, and Greg, you had mentioned heart failure has been around a long time, obviously, but we tended to treat the earlier entry part of it on the mitral, the tricuspid, and we're solving that problem. But now, are there devices out there that can be tunable because every patient is different, every anatomy is different as we manage heart failure that we see in a TCT?
Sure, well, it's a big question. So first of all, there's a whole number of sensor technologies which are designed to measure intracardiac pressures and guide better therapy for heart failure. Then after that, you mentioned the valve therapies, okay? So obviously, treating secondary mitral regurgitation and heart failure has made a huge impact, and for patients with aortic stenosis who develop heart failure, treating aortic stenosis has made a huge impact. Then we had cardiac contractility modulation, and then baroreceptor activation therapy. And now there's a whole series of new devices and new approaches to treat either fluid overload or rises in intracardiac pressure, which are the proximate causes of most cases, left atrial pressure in particular, of both heart failure hospitalizations and poor symptoms. And the intraatrial shunts in particular, I think, have gotten a lot of attention for their very low-tech, if you will, low-risk approach to reducing left atrial pressure.
And when we think about a platform, just as an example like Odana, where we've got that ability to tune this and really customize it both from an implant perspective, adjustment, and then ongoing on the diagnostic and then therapeutic side, how do we think about that?
Yeah, I mean, if you look at a patient with any sort of disease process, and if you're going to treat them pharmacologically, it's never a static dose for their duration of their disease process. It's an evolution. Sometimes you go up on medical therapy, sometimes you go down on medical therapy, and you continue to do that. So if you talk about shunt-based therapy, prior to Odana, I mean, all the shunt-based therapies are static. And somebody's disease process now may look very different than 2 years from now, than 4 years from now, and 5 years from now. So having a device that's able to, based on that particular patient's pressures, their needs, their physiology, to adjust the amount of shunt, increase it or decrease it, really allows for this concept of precision, management. And this is something that our heart failure colleagues do now routinely, and now with this type of device and this type of technology, you can provide that as well.
And as a heart failure specialist, do you think now about the, let's call it the chorus of therapy that goes on where you talk about pharmacological and then you talk about a tunable, implantable device? Does that potentially offer a larger strategy for the patient?
Absolutely. I mean, I think it's, as Gagan said, it's really titrating to the disease, right? And the disease today is going to be different than the disease 6 months from now. So not only you can improve the patient's symptoms and hemodynamics, but potentially in some cases you can prevent harm. So we have, shunts that have been in studies, and some have shown that in heart failure with preserved ejection fraction, there may be a harm signal. And then having a potential to adjust during the shunt procedure and monitoring, the hemodynamics and adjust the shunt may actually prevent that harm. So I think it's very important.
Yeah. And Greg, you mentioned you had run this show for 20 plus years. What does it mean to you to have heart failure specialists now on the floor with the interventional cardiologist and looking at problems maybe from a different sort of perspective, but still coming together to solve them?
Well, I think it's fantastic because the heart doesn't stand on its own, right? The heart affects every other organ in the body, and every other organ in the body affects the heart. So we have to think of cardiometabolic disease. We have to think of cardiorenal disease. And when you look at heart failure, obviously we have to understand the neurohumoral aspects of heart failure, the renal effects of heart failure, et cetera. So heart failure specialists should be here. And I think now they're becoming increasingly open to understand that device-based therapies can actually have as great or even a greater impact to the prognosis of their patients than medications, which are very difficult for heart failure patients to take. The older they get, and these patients often are quite old with multiple comorbidities, it's very difficult to take 4 or 5 heart failure meds on top of maybe 5 or 6 other medications that they're taking. And so if you can have a simple, low-risk, device-based solution that can reduce heart failure hospitalizations by 50% and mortality by 50%, that's a great option for patients.
Well, I'm going to leave it at that one for what we're talking about today. Thanks for bringing it home and wrapping it back around. Gentlemen, I appreciate your time today.
Thanks for having us.
Thank you.
Thank you. I'm Joe Mullings from the floor at TCT 2025 in San Francisco. Be well.